If that pump isn't working, as you see in Fuchs, are you guys with me? With Fuchs endothelial dystrophy, then who's going to come into the cornea uninvited? Aqueous humor, the fluid. Not good, not good. Okay. Now, once that fluid comes into the cornea and fills up your stroma like a sponge, it's going to cause major damage, and you will see a particular pattern. If this cornea is getting heavy like a sponge, it's going to sag, isn't it? It's going to sag. And that sagging is a drop-like configuration. And that drop-like configuration is called a goutte. All right, we'll see that in the next slide. But are you understanding the process? The endothelium is not working. The pump isn't working. The fluid comes into the cornea. Now at this point, it's getting heavy. It's going to form a drop-like pattern. It's known as a goutte. Please know this. So, if you take a look at the endothelium on your left, normal human, corneal endothelium. How do you know it's normal? Because you have nuclei. In Fuchs, in Fed, you don't have the nuclei. The endothelium is dead. If that endothelium isn't working any longer, who's going to come in uninvited? The fluid, the aqueous humor. Okay, and that's your picture on your right. Yeah. And there's your goutte. Just in case you don't see it. See, this is supposed to be nice and smooth. These are dead endothelial cells. This is a consequence of FED. And that fluid that was coming in, what it caused the cornea to do? Become very soggy and heavy. And the goutte is this right here. These little drop. It doesn't drop per se. It's just a drop pattern. Okay? And then the goutte itself, obviously, it was an architectural term, this and that, and they actually use it in ceilings and rooms, so on and so forth. And how you would go about seeing it, you have different mechanisms here. You have your confocal microscopy. Here's your scatter refractal. But you understand the process. You understand why the goutte begins or how it develops. Then, this is still Fuchs. Why do you see bulle? What's bulle? Accumulation of fluid? Accumulation of fluid where? In this particular case. In the stroma. Stroma of the cornea. Good. More pictures for your entertainment. Here's a goutte. Yeah, both are on the same slide. How about that? Got a goutte, and you have bulle. Goutte, bulle, goutte, bulle. And here's the individual with FED, and then obviously, what part of the cornea are you going to take out? You're going to take out the bone membrane? No. Please don't do that. Take out the descemetous membrane. Anyway, that's just for your own. This is before and after surgery. You take out the descemetous membrane. This is a corneal transplant. Amazing. All right, now keratoconus. So we're done with. We're still in the cornea. Still in the cornea. Done with the corneal dystrophies. There was epitheliostomal, but the one that you will be responsible for will be Fuchs. Okay. Now, keratoconus. Basically, what happens here is that you have a dome-shaped cornea, which becomes cone-shaped. Keratoconus. Cornea, conus, cone. Put them together, you have keratoconus. What happens here is that you have your epithelial cells. All right, epithelial cells, superficial, not deep. Who's deep? Fuchs is deep. Superficial is your keratoconus. What's going on? Well, for whatever reason, you might be rubbing it too much. There's a supposedly, not quite sure yet, but there seems to be a genetic predisposition. This individual rubs his eye too much. Contact lenses, they've said, any type of irritation, persistent irritation. And what ends up happening is that the epithelial cells of the cornea is protruding towards you. And when that is happening, it ends up becoming cone-shaped. Not dome-shaped, cone-shaped. I have a really good picture. And who's at the bottom? The descemetous membrane. And if you pull and pull and pull, what's going to happen to the descemetous membrane? Whoop, spring right out. And that's your bottom picture. Are you guys with me? So who's pulling out the epithelial cells? Who's in the back? The descemetous membrane. If you pull enough, are they going to be strong enough to sustain that pull tension? Absolutely not. At some point, you're going to break it. And it's exactly what happens. What is this? Keratoconus. Keratoconus. And take a look at that. See things rather clearly. All right, now we're at the lens. With the lens, so now we're done the eyelid, we did the conjunctiva, we did the cornea, and we're heading to the lens. More anatomy. And please pay attention. Anteriorly of the lens are epithelial cells. How do you know they're epithelial cells? See the nuclei? See the nuclei? There's epithelial cells anteriorly. Posteriorly, there are no epithelial cells. How do you know that? No nuclei. So, now, things that I will hold you responsible for as far as the lens is concerned. Cataracts. Okay. Now with cataracts, I need you to pay attention to age, and I need you to pay attention to torch. You guys know what torch. Well, it's torch is, right? Right. Congenital rubella, particularly. Okay. You guys had this in micro. Congenital rubella. Diabetes. There are a plethora of causes of cataracts. But like I said, age is the most common. Age is the most common. You also see it with diabetes, and you also see it, you could see it with congenital rubella. Comes from the Greek word katarrhikes, nutritional deficiency, drugs, physical agents, ocular diseases. We will cover uveitis, we'll cover neoplasms, retinitis pigmentosa, retinal detachment, conjunctivitis, and congenital rubella. Now, here, look up, because I need you to understand this as well. Now we're in the lens, another process. With age, your lens deteriorate. Okay, your lens deteriorate. Phaco means lentil. Who looks like the lentil? Lens looks like a lentil. Wasn't a trick question. All right, so the lens deteriorates. Why? Because what I say the most common cause of cataract was? Age. Right, absolutely. Good. So as the lens starts deteriorating, phaco is lens. Morphic. What does morphic mean? Shape. Okay, so you have phacomorphic glaucoma. Well, we'll cover glaucoma a little bit, but point being is cataract, age, phacomorphic, the initial stages in which the lens is deteriorating. Okay, as the lens deteriorates, who's around the lens? Aqueous humor, right? Fluid. Now, as the fluid enters the lens, it's going to deteriorate further. Okay, and that is your phacolytic. Phaco, once again, lentil, lens, lytic, lysis of what? Your lens. So the initial stage is phacomorphic. Are you guys with me? The shape of the lens changes. Why? Because of age. It just deteriorates. And so therefore you start forming these fissures, the little lesions in there. And then your fluid starts coming in, and then eventually you start releasing your lens. So it's basically stages. And it's basically all that I need you to know as far as age and cataracts. Phacoanaphylactic. Phacoanaphylactic is, what's anaphylactic? An immediate immune reaction. Phaco, once again, is your lentil. So what ends up happening is that your lens, your body, for whatever reason, it's an autoimmune process in which your lens will release your substances or whatever, and it will react to it. That's what phacoanaphylactic means. But point being here is please know phacomorphic and phacolytic and know what the difference is. And that's basically what I'm saying here. Phacoanaphylactic endophthalmitis is basically all that you need to know is that this is your lens in which as it goes through deterioration, it will release substances to which you have an inflammatory process. Okay? Anaphylactic. All right. Scatter keys. And the way they presented this was rather interesting, actually. It's just as a waterfall, as the water falls through down, as it progresses, it becomes cloudier, doesn't it? It's just because of the mist and stuff like that. And that's how they basically came up with cataractes, or cataracts. It means waterfall. All right, uveal disease. We do uveal. This will be our last one, and then we'll take a 5-minute break. Uveal is dealing with your iris. Okay, so we did our eyelids, we did our conjunctiva, we did our cornea, we did our lens, and now we're going to the iris. All right. Now with the iris, uveitis is what we'll pay attention to. Okay. So this is all of these will come under uveal diseases. However, uveitis will be the inflammation of uveal tract, which is all part of your iris. The part that I would like for you to pay attention to, 70% is idiopathic. However, what they love are the systemic diseases. All right, so let it be ankylosing spondylitis, Reiter's syndrome, IBD, psoriatic arthritis. So if you see a case scenario on your boards in which it is presenting with any one of these systemic conditions, please know that it's associated with anterior uveitis. What's uveitis? Inflammation of what part of the eye? Where are we? Iris. Yes, iris. Now let's take a look at what this looks like. We saw a picture earlier when we were taking a look at the dendritic presentation of herpes. And this is anterior uveitis. So what ends up happening here is that you have congestion of the ciliary body. Okay. And there are vessels near the cornea, and that is the diagnostic sign. When you see vessels near the cornea, that is the diagnostic sign. And in addition to that, you also see flares. Where is all of this? Well, see, look, here's the iris, right? And here's the cornea. If your iris undergoes an inflammatory process, uveitis, then it's going to start accumulating proteins, and you're going to start having WBCs. And then if you actually take a look at a patient, here is that congestion we're talking about around the cornea. But then here is your hypopyon, or hypopyon. And that is filled with your WBCs, and that is filled with your protein, flares, and cells. Okay, this is all part of anti-uveitis. And where else would you see this possibly associated with? Systemic diseases such as ankylosing spondylitis. You have a 52-year-old lady who has tremendous back pain, extremely stiff or whatnot. Okay, you do an HLA, whatever, it comes back to be, what, DR4. And they ask you, what are you worried about in this patient? And you see a bunch of eye conditions. You're like, what? Anti-uveitis. Sympathetic ophthalmia. I'm going to skip over this. You will not be responsible for this. And we'll take our break.